Hello, my name is Nicole Juffermans. I'm an intensive care physician from Amsterdam, the Netherlands. And in this session on specific patient populations in sepsis, we will talk about hypothermic sepsis. It is my experience as a clinician that we always ask about fever when we think that a patient may have a sepsis. And if the fever is not present, well, we are reassured, or the suspicion of sepsis goes down a little bit. But in fact, sepsis can present with all kinds of body temperatures. So a large group of sepsis patients do present with fever, but the larger part of patients are either normothermic or hypothermic. And this really is my key take-home clinical message, is that I think that we should also ask and be more aware of hypothermic sepsis. And why is this relevant? Well, the mortality of patients with hypothermic sepsis is twice as high as compared to patients who do not have hypothermia, so either normothermia or fever. So these data are fairly consistent. This is another data set presenting the same thing, showing that patients with hypothermia, and these are the blue and green arrows here, have a decreased survival compared to patients with a normothermia. And you can see here reflected in the odds ratio in the table that the more hypothermic you become, the higher your chances of dying are in sepsis. Well, what about fever? Is that detrimental, or is it perhaps protective? Well, the presence of fever in sepsis compared to normothermia does not alter your risk of dying. So this risk of dying is solely related to the hypothermia. So it is also a fairly consistent finding that patients with hypothermia in sepsis are more severely ill, as reflected by more deranged disease severity scores and more shock and more organ failure, etc. So you can think, okay, that's the reason that the risk of mortality is higher, or is there something specifically related to hypothermia? If you try to model for that in a multivariate analysis, you can see that the odds ratio for dying of hypothermic sepsis decreases, but it remains statistically significant associated. And this suggests that, at least in part, hypothermia may be an independent risk factor for mortality in sepsis. So with regard to pathophysiology, if you think of fever as being part of an adequate immune response to an invading microorganism, you could regard hypothermia, the lack of the mounting of a febrile response, as a defective immune response. So this is work from Dr. Hodgkins, comparing hypothermic patients to non-hypothermic patients. Again, you can see that they are more severely ill and that the mortality is higher. And what he showed is that hypothermic patients have a persistent lymphopenia. And this could be, in fact, an indicator of a defective immune response. However, if you look in other domains of the host inflammatory response, well, the evidence is not all that clear-cut. Here you can see cytokine levels, which are being measured at ICU admission. That's day 0, day 2, and day 4 of ICU admission, so throughout the course of a sepsis. And you can see that these interleukins are severely increased in sepsis, and they diminish a little bit over time. But you can also see that there really is no difference between those patients with hypothermia as compared to those without hypothermia. And if you want to evaluate the host immune response in a different way, you could also do whole blood stimulations. Well, how do you do that? You take whole blood from a patient containing full red cells and also all the immune cells. You take ex vivo and you stimulate this with a bacterial antigen. In this case, that is LPS which is a bacterial antigen of E. coli. So in normal situations, if you stimulate immune cells with a bacterial antigen, these cells react by mounting of a pro-inflammatory response and the production of cytokines, TNF, IL-1, IL-6. So you can see that reflected here in the white bar. This is from a healthy individual showing strong TNF and IL-1 and IL-6 response when stimulated. In contrast, if you take plasma from a hypothermic patient or whole blood from a hypothermic patient and stimulate this with LPS, there is a blunted response. And this is very well known. It's LPS, called LPS tolerance. But what you can see here is the patients with hypothermia do not really do any worse than compared to patients without hypothermia. So again, this doesn't point towards a really a distinct defective immune response. So what about clinical risk factors? You would perhaps think if there is a deficient immune system, patients with cancer or with immunosuppressive medication would be more prone to become hypothermic during sepsis. Well, this is not what we find. We find that patients with a low body mass index are more prone to become hypothermic. I think this has some rationale, and it's the case for every hypothermic situation. But we also found that patients with hypertension and patients with chronic cardiovascular insufficiency are at an increased risk of becoming hypothermic. So this sort of implies that the cardiovascular system or the vascular system may be involved. And another finding that may point towards that direction is this, and that is that we found that fractalkine is increased in hypothermic sepsis. Fractalkine is a chemokine that is being produced from endothelial cell, so that points toward endothelial cell activation, and this marker was increased in hypothermic patients as compared to non-hypothermic patients. Although, if you look at other markers of endothelial cell activation, such as ISICEM or E-selectin, these were not increased. So again, this signal is at least, there may be something there, but it's not super strong. So where are we now in terms of pathophysiology? We're not sure. It may be the immune system, it may be the cardiovascular system. So we thought, okay, let's take a broader approach to find a way to better understand the mechanisms, what is driving hypothermic sepsis, given that it's such relevant to outcome of patients. So you can do that by looking at a wide array of gene expressions with microarrays. And here we looked at a large variety of gene expressions from blood leukocytes, and we compared patients with hypothermia compared to those with fever. And these are this generates these kind of heat maps. So the genes that are upregulated are shown in red. The genes that are downregulated are shown in blue. And this may generate certain patterns that can lead you to certain pathways. So these are the patients that we compared, a hypothermic group and a fever group. And again, you can appreciate that the hypothermic ones were more severely ill and that the mortality is 43% versus 16, so more than twice as those with fever. And when you compare the gene expression profiles, yeah, we call this a volcano plot. That's just shown here. You can see that the genes that are increased are shown in red and decreased are shown in blue. And the gray dots here, that is the expression of genes that overlap with those patients with fever. So you can see that there's actually a wide range of pathways that are being either upregulated or downregulated during hypothermia. And this generates really a quite different gene expression profile compared to those with fever. And these pathways are very broad, and they relate to inflammatory pathways, immune response pathways, but also to pathways involved with the degradation of noradrenaline and adrenaline, or in the glucocorticoid receptor signaling. So this may indicate that you can imagine that if these genes are dysregulated, that this may impair an effective hemodynamic response to sepsis. We also thought it was of importance to match these patients for disease severity, because you can imagine that disease severity by itself will generate a whole lot of differences in the upregulation and downregulation of gene expression. This is well known. So what happens if you match the patients for the cohorts for these parameters? You can see that there are only 3 pathways that remain that are significantly different between the groups, and these were 3 pathways that were upregulated. 2 of them related to the regulation of anti-inflammatory response, and there was 1 pathway that was involved with catecholine synthesis. So again, this points towards the direction of, well, an inability to perhaps maintain hemodynamic stability. So in terms of management of hypothermic sepsis, I think as doctors we tend to want to normalize deranged parameters. So we tend to want to rewarm patients, perhaps thinking that a deranged body temperature needs correction. But the question is whether this is, if hypothermia is detrimental and it should be corrected, or whether it's just a bystander of disease severity and it can actually be an adaptive response. And there is some evidence pointing towards the latter. In animals, if you subject animals to severe inflammation or sepsis, they do better if you put them in a cold environment. So their survival increases versus those animals which were kept in a warm environment. And also sick animals, they display cold-seeking behavior. So they want to go to a cold environment. So this may point towards an adaptive response. Another observation that has been done in hypothermic sepsis patients who are not rewarmed, so no intervention applied, you can see that actually these hypothermic episodes are transient. So they come and go over time if you don't interfere with the body temperature. But then again, this doesn't say much about the whether you should how you should manage them. And in fact, there are no data guiding us on this point. We sent out a survey asking people about clinical management of hyperthermic sepsis with the question, should patients be rewarmed? And you can see that the majority thinks that they should be rewarmed, but there's also a substantial proportion that thinks that these patients should not be rewarmed. And I guess this, just points out the lack of data that should guide us in the best management. So opinions differ, not so much related to the definition of hypothermia, because most of us define hypothermia as a body temperature below 36 degrees, but we do very much differ on, trigger for rewarming. When do you really start rewarming your patients? So there's a wide variety in practice on this. And also the target of the temperature that you want the patient to go to is very different, and also the rate or the speed of rewarming. We have different opinions on this. So I guess this really points towards the need for more data and the need for more good research on this subject. So with this, I would like to conclude. I've told you that hypothermic sepsis is not uncommon. I think we should be more aware of it in our clinical practice. Hypothermic sepsis differs from febrile sepsis. It may be a distinct entity, and definitely it has a high mortality, which puts the call on us as clinicians to try to find ways of our optimal management. For the mechanisms, I think the jury is still out. We don't know really. It could be related to a defective immune response. But I also think that the cardiovascular status may also play a role. And again, the optimal management is not known. And with this, I would like to end my talk, and I would like to thank you for your attention. And I say goodbye.